also can be very important when you are distinguishing why these symptoms are worsening or how they're presenting. A patient with dementia can have any of the symptoms that Teresa kind of went over, but there are specific things that can also kind of come as those symptoms as well. So delirium is something that can occur. Typically it occurs with a infection, medication effect, metabolic imbalances, severe chronic illnesses. But that can present as worsening cognition. Patients can have hallucinations, delusions, they can have agitation, aggression. So when a patient has BPSD or is newly being diagnosed with dementia, it's really important to establish what their baseline is. And then when those symptoms are different from their baseline, you're evaluating what that cause is. It's easy sometimes for patients with dementia to start having these symptoms and say this is their dementia. We want to make sure that we're ruling out that it truly is and that it's not something else. So delirium can present. It's treated differently. You would treat the underlying cause of the delirium and hope that those symptoms resolve. Sometimes you would use a medication to help with those symptoms in the interim, but you would be treating it differently than if you were assuming that the BPSD symptoms are simply worsening. Depression, it can also manifest as cognitive impairment. So a patient who has dementia, who suddenly has this decline in their symptoms, if they are experiencing depression, that can make those symptoms worse. And so again, reevaluating between, is this really their dementia symptoms or is there something else that's causing this? We usually use a cognitive screening, MMSE. I know a lot of times in the nursing homes, you guys are AL, we do know that. Use the BIM screening. I like the SUM screening as well to kind of establish that baseline cognition and be able to reevaluate if they're having that decline in cognition. And then also doing your typical screenings for depression. There is a depression screening that you can use with patients with dementia, that's the Cornell depression screening. We also will utilize the geriatric depression screening. It asks the questions a little bit differently than the PHQ-9, that they typically can understand a little bit better, and then you can also utilize the PHQ-9. Again, the treatment for someone who's depressed versus really worsening dementia can be significantly different. And then there's other causes as well. Patients who have untreated pain, environmental triggers, excessive noise, other, disruptions in their day, that can cause their symptoms to be a little bit worse in that time period, and it doesn't necessarily require the same level of treatment as if it really were their true disease state progressing. So it's important to be able to rule that out and distinguish what the cause is. We're going to go over some non-pharmacological interventions. I won't make Dr. Nettleman stand up for the first one, but he's the expert, so if Dr. Nettleman wants to talk a little bit about psychotherapy.
Yes. So psychotherapy can be helpful. It's a little bit tricky because on the one hand, we have enough research evidence to suggest it helps. On the other hand, it's kind of hard to advocate talk therapy for people with advanced dementia, at least to people who pay for the service. So we're generally don't have any issues providing counseling to somebody whose cognitive impairment is mild, but it does get a little tricky when someone has moderate to end stage dementia to be able to provide proper counseling. But it can be helpful to be able to teach them coping skills. And one of the things that I always tell my providers is you're not going there just because the patient needs someone to talk to, but that's a benefit from counseling is they have someone to talk to. So even if you feel like you're not being very helpful as a provider, it does make a lot of difference to the patient to have a counselor.
Thank you. There's also reminiscence therapy, which is really just talking about their past, and anybody can do that. So when we educate staff on some non-pharmacological interventions for dementia, looking at just how can you incorporate things into your everyday routine that can help the patients have a better quality of life and hopefully reduce some of their behaviors. Simply, if you're feeding the patient, asking them questions that allows them to think about their past happy memories, can be just a simple task that makes them feel better. I always remind people, make sure that if it's not making them happy, to stop. and not agitate them further, but that is something that you can easily incorporate in the day-to-day routine. Sensory interventions are important as well. There's different types of actual interventions that are proven out there. I know there was one when I first started as a nurse practitioner that I found really interesting, which was music therapy. So they would select music that the patient was enjoyed. Usually it would be the loved one or a family member that would pick that out for them if they couldn't remember, and utilize it. And I remember I had a patient who, she would wheel in her wheelchair all day, but she would run into people, like everyone in the halls. She would run into walls. She was very kind of agitated and aggressive, and they had suggested using this music therapy, and they had an iPod for her to listen to. And I was like, that's, we can try it, but I don't know, she's very aggressive. It actually worked, she's very calm. I mean, she still had periods where she would become very agitated and aggressive, but for most of the day, she really would just sit there and listen. So some of those things can work. The most important thing with sensory interventions is you have to look at both sides, right? You don't want to overstimulate, and you don't want to understimulate. So looking at not only, sounds, if it's very loud, it can often agitate people, versus, if they're bored, it can also agitate them, right? Same with lighting as well. So looking at what's best for the patient, and we'll talk about person-centered care here in a minute, but personalizing it to them is the most important.
Can I interrupt with something?
Yeah.
So I have 3 boys at home, all under 7. So today when I woke up in the hotel, it was very quiet and I had time to think. So I thought it was a great idea. So I need 4 volunteers. I'm going off script. I probably should have told you. I need 4 volunteers. Okay, I need somebody who doesn't have epilepsy. Can you raise your hand? I saw you first. Man with the mustache. All right, come on up. I need someone who isn't afraid.